diagnosis is schwannoma, not a cellular or malignant schwannoma. This is a classical schwannoma. Let's review the characteristics. Grossly, very classical, a yellow tumor, yellow-gray tumor not attached to a nerve, with myxoid and gelatinous areas, well circumscribed, apparently completely excised. The lesion is multinodular, but it doesn't look plexiform. The patient has no history of neurofibromatosis. Here, compact interlacing bundles of spindle eosinophilic cells in Anthony A areas, alternated with myxoid hypocellular areas, Anthony B. This is an Anthony B area with spindle eosinophilic cells in a loose myxoid stroma with few mastocytes. There are some mastocytes in the background, and I know that there are mastocytes because they are calretinin positive. Something that is characteristic of Anthony B areas is tortuous, dilated, hyalinized vessels. I don't see this kind of vessels here. Again, this is an Anthony A area with interlacing fascicles of bland cells, no mitosis, and that argue against the possibility of cellular schwannoma. Here, the palisading areas with parallel rows of cells with fibrillary processes in between, it's called verrucai bodies. Also the whorling, very characteristic of Anthony A areas. Here, some thickened hyalinized vessels in the Anthony A area, more characteristic in Anthony B pattern. The tumor is very well encapsulated, and it was apparently completely excised. Immunohistochemistry, very typical, S100 diffuse and strong, characteristic. BCL2 was positive according to immunoquery. 80% of the cases are positive for BCL2. CD99 was positive, kind of unusual for schwannoma. But remember that CD99 is the marker that stains 99 different things, so many things marker that this is not really specific. Calretinin, some schwannomas are positive for calretinin, this one is negative. CD34 usually shows some scatter cells in schwannoma. Here is negative, and probably the positive cells in the picture are fibroblasts. Desmin and smooth muscle actin, negative, rule out leiomyosarcoma. EMA, negative, not highlighting here the fibers of the epineuron that normally are EMA positive. The tumor shows no mitosis, and Ki67, in my opinion, is less than 3%. Less than 3% is very typical of schwannoma and rule out cellular schwannoma or malignant schwannoma. So the diagnosis was very typical for a schwannoma, a tumor that is relatively common in head and neck, not an atypical cellular schwannoma or malignant peripheral nerve chip tumor, completely excised with margins apparently negative, but I always recommend in a comment follow up, because even after success removal, schwannomas recur in 5% of the cases.